Thank you for the invitation from ANZICS organizer. I was particularly told not to speak about end-of-life care nutrition and ECMO, which is my favorite topic. So today I'm going to switch a bit and talk about, in general, how ICU nurses can contribute to a service and how to improve or to close the gaps in management of critically ill patients. I have no disclosure. I've put up a list of possible problems that we may encounter day in and day out in relation to intensive care. This is not an exhaustive list, but they are commonly found in different ICUs. For example, there can be conflicts in triage. The surgeons want to get the patient in your ICU, but your ICU bed is either full or the physicians think that the patient is not a good candidate to be nursed in ICU. There can be bed blocks. It can be entry block or exit block. And premature discharge and early ICU readmission is often possible if you do not have enough ICU beds. Sometimes the critically ill patients may have to be nursed in the general ward setting, and that is not desirable. And admission of a patient in extremist condition to ICU is always a problem, and there can also be procedures with increasing complexity that we have to deal with. For example, again, ECMO is one of those. And of course, there are many administrative issues that nurses have to deal with. For example, there are always an influx of new generation nurses to our ICU. So that dilutes the clinical skill of the team. And their senior nurses sometimes, because of pursuit of different commitments or pursuit of different jobs, they have to leave the ICU. So staffing is a problem as well. So if you look at the patient journey, in the past, ICU nurses always work within the walls of ICU at the yellow triangle area. However, if you look at the current model, there are nurses who need to work in ED to provide resuscitation service, or even work in other hospitals to provide patient retrieval service or patient escort service. And of course, there are times when ICU nurses have to move outside ICU and work in the general setting, and that poses a lot of challenges to them. So, as you can see, critical care patients can be anywhere. It is not only confined to ICU. They can be in the HDU, acute ward setting, in other hospital and ED. So that makes that intensive care nursing will also be practiced in different parts of the healthcare system. So what are the areas that nurses need to address in contemporary ICU service? I think if you stratify it into ICU and outside ICU areas, then for intensive care settings, mostly advanced practice nurses has to manage and set goals for high complexity cases. They have to confine clinical risk. They have to prevent complications and nitrogenesis, and to hasten the patient's recovery. And for example, for centers, we adopt the rehabilitation program well in ICU rather than discharge the patient and let them have their recovery role unaddressed. And of course, as a part of the quality care, we should provide good end-of-life care for the patients, and also to support service development for the unit. And when it comes to the general ward setting or step-down unit that is outside ICU, ICU nurses' role mainly is to support management of the critically ill patient to ensure quality of care after ICU discharge. This is very important, especially if you want to minimize ICU readmission, and of course to identify clinical risks and contain clinical risks, and also the standardized practice. Because if this part is not done properly, then the patient may deteriorate, or the nurses in the general ward do not know how to manage critically ill patient, and that will result in poor patient outcome, delayed detection of deterioration, and possibly admission of patient in extremis into ICU. So at the ED or other hospital level, of course, ICU nurses play a very special role in resuscitating patients and coordinating different plans in advance before something disastrous happened. And also, nurses will provide patient retrieval services. So in the following time, I'm going to draw upon an example of a project that we have conducted some years ago in our ICU as an example to illustrate how nurses actually work beyond the four walls of ICU and go to the general ward to provide the service. So in Hong Kong, for organ donation, we use an opt-in system. That means the people has to sign a donation card so that they to express the wish to donate organ. And as you can see here, I just show you the figures from 2011 to 2014, but the situation is very much the same nowadays in the recent 5 years. So you see the kidney donation rate is about 60 per year, and the liver donation rate is about 40 per year. However, the patients who are waiting for organs per year for kidney is over 2,000, and those waiting for liver is over 60. So there's a huge gap between disease organ donation and patients who receive a transplant surgery. So and we look at our hospital, and the service gap is that for those imminently brain dead patients and potential organ donors, they were nursed in general ward. And the management of this group of very critically ill patients falls into the hands of the organ donation coordinator, and they provide management advices to the clinical team. Unfortunately, they are not readily at bedside. Sometimes, especially during weekends and public holiday, they just have, you have to call them up. And at the time when they receive the call and feedback, there will be much delayed in providing advice to the clinical team how to manage the patient's problem. And because of the nurse-patient ratio in general ward, there's a huge gap between family expectation and what they actually received in relation to psychological care or attending to their information needs. So the objective of our project is to have protocolized referral of the imminent dying brain dead patient and the potential organ donors to ICU. And we want to open up an expedited admission channel for such patients to ICU and to provide outreach service if ICU beds are not available. And we want to dedicate an ICU specialist to manage these patients in particular, and also to provide training and education in relation to brain death concept and the conduction of brain stem tests to the ward staff. So what have we done? The ward team, actually, we request them to screen the patients based on established criteria. So the criteria are the GCS equal to or less than 5. The patient is intubated and ventilated. Their disease is deemed irreversible and is receiving end-of-life care. So the ward team will, after identifying these patients, they will call up the ICU physicians and ICU lead, the head nurse, and so that we will go to the ward and assess the patient, and together with the ward team, we will have a family meeting with the families, explaining the condition. We deliberately leave it to the ward team while our team is actually supporting at the side, because we think this is the primary responsibility of the ward team before we set in. And if the family agrees, then we will either admit the patient to ICU or we'll send a team to the general ward to support the patient. And after optimization of patient's condition, then brainstem tests will be conducted. So the composition of our critical care outreach team consists of 1 ICU physician, 1 registered nurse. She or he has to have specialty training before. And there's 1 advanced practice nurse who coordinated the manpower and patient care issues. So the role of this ICU outreach team is very specific. Their role is neutral. They are not there to persuade the family to agree upon organ donation. Their role is just to support the critically ill patient in general ward setting, so their roles are neutral. They support the work of ward physicians, nurses, and ODCs during the process. And actually, they are there to set up a satellite ICU bed unit in the general ward and to provide bereavement care for the family. Also, so what they actually do at bedside is that they provide intensive monitoring and support to the patient. For instance, they will set up arterial line on the patient, which is not done usually in a general ward setting. Central venous catheter, it depends on the patient's condition. Usually, we do not require that. But if the patient's blood pressure drops to a significant degree in which we have to start vasoactive agents or vasopressors to support the patient, then we will set up CVC at bedsides. Ventilator management, that's always a problem for general ward nurses because they do not have related training. And management of diabetes insipidus, tight glycemic control, and temperature management. So basically, we have what we are doing in the ICU, and we move it to the general ward setting and provide those care at the bedside. And the ICU physicians will provide management advice to the ward physicians, and joint hands, they will work together. And it's the same for the nursing team. And eventually, hopefully, we can optimize patients' condition for a brainstem test. So these are the protocols that we use to manage the patient in relation to blood pressure, SATs, and urine output, and also glycemic control. So when will our ICU team withdraw? We'll withdraw if the patient is considered non-salvageable and no longer benefit from a service. For example, before brain stem test, that being a time when the patient becomes unsupportable and eventually died. Or after brain stem test, the ODC discuss with the family, and family opt not to donate. So there is also a time where I think we should go on and refer the patient to the team instead of continuing ICU support service. So those are the criteria that our team will withdraw. Or if the patient's family opt to donate the organs, then we will continue support of that potential organ donor until the organ harvest surgery. So what are the results? The project was commenced in February 2015. Here I'm showing you the data from 2015 and 2016, which is our data that are published and available in the internet. I've not shown you the data in the recent 2 years because they are unpublished and my hospital think that it's a bit sensitive to be shared in an international conference. So for the published data, as you can see, for the first about 2 years, actually 23 months period, the duration of our outreach support is about 8 hours, and the mean time from intubation to brain death is about 31 hours. And the primary diagnosis for these patients are brainstem hemorrhage, ICH, subdural hemorrhage, and hypoxia. And here are the results of those patients in the first 23 months of our service. In total, we received 15 referrals. 8 of them were admitted to ICU eventually. And the rest, we nurse it in the general ward and provide outreach service in the general ward. And as you can see, 2 of these 15 patients eventually do not fail the brainstem test and have to underwent confirmatory tests. And 1 patient, after admission to ICU, we noticed that the patient is actually not brain dead. And out of these 15 patients, eventually the family of 5 patients agree with organ donation. So 4 livers, 3 pairs of lungs, and 4 pairs of kidneys were procured. So what are the challenges that we have encountered? Of course, stress is always a problem. We are now taking off the stress from the ward staff, but on the other hand, we are adding stress to the ICU staff because they are working in an area that they are not familiar with. And unfamiliar environment is, again, a problem. The resources in the general ward is very limited. We have to very often bring our ready-to-go bag, which contain the equipments, and to bring them to the general ward to provide the service. But definitely, obviously, we cannot bring every piece of ICU equipment to the general ward. And unfamiliar equipment is also a problem because, as you can see, this is a very old model of a ventilator. And however, because the patient is very often put on this type of ventilator, so our ICU nurses have to be familiar with this ventilator, which were used in general ward as well. And there's always a tension in nursing manpower, especially during night shift. So in conclusion, I think contemporary practice of ICU nurses is no longer confined to the practice in ICU, and nurses need to be highly skillful and adaptive to providing nursing service in different environments, and collaboration with different disciplines and different stakeholders is the key to success. And I would like to acknowledge my team, which put up with this very good project, and thank you for your attention.